Amazing. Oh, thank you so much, Julia. Right, we'll kick off then, shall we? I'm so pleased to be here and to be kicking off the new academic year. So thank you so much, Julia, for the invite. And yeah, thank you everyone for coming along and listening to me talk about positive body image and the prevention of eating disorders. Last time I looked, there was over 100 people here, which is really encouraging, I think, to know that there's over 100 people in the country who work in educational settings who care about this topic, perhaps as much as I do. So, yeah, really happy to have you all today. Like Julie said, I'm a postdoc research fellow at the Centre for Psychiatry and Mental Health as well, and I work across the Youth Resilience Unit and the Unit for Psychological Medicine. And I'm funded by all these bodies that you can see at the bottom of the page and work in collaboration with the University of Cambridge as well. So I guess just before I get started, I'll tell you a little bit about myself, and I'd be really interested as well if people were keen. I know there's loads of you, but to hear a little bit about who we've got in the virtual room. So if you did, or if you were able and wanted to, drop a little note to say, I guess, like your role, whether it's in a school setting, a mental health support team setting, or another mental health setting where you're working with young people. It would be really nice to know, I guess, your experience of working with body image and eating disorders. It'd be helpful for me to know, I guess, where to pitch this talk. So yeah, if you can do that, that would be great, but no worries if not. So like Julie said, my name's Hannah. I completed my PhD last year and I've been really lucky to get 2 further years funding to kind of finish what we started. I started my PhD at the beginning of the pandemic, which is not recommended. But yeah, really grateful to NIHR for giving me that postdoc fellowship. So could really just like keep going with the good work we were doing. So I would describe myself as a policy researcher specialising in children and young people's mental health because I'm really interested in how we can sort of bridge the gap between what initiatives are coming out of government and what we as researchers are doing to, I guess, mobilise our knowledge and translate all of that onto the ground. So the specific area that I've been looking at is school-based programmes which promote positive body image and prevent the onset of eating disorders. And I've had a specific interest in my work on ensuring that these are rolled out in a really inclusive way, which prioritises intersectionality. And you can probably tell by like some of the words I use and the way I work that I have a background in the charity sector. So things like co-production and having that sort of policy-driven mindset is very much at the forefront of all my work. But I'm going to start today just by giving a bit of an outline of what body image is, like what am I actually talking about when I keep going on about promoting a positive body image, what does that actually mean, and why I think you should care and why I think it should be a priority for people working in school settings and not just, I guess, a nice to have. I think it should be something that's front and centre of that agenda. So to support you in getting it on your agendas, I'll go through a few opportunities there are to intervene in that school context at various levels. And then, like I said, I'll go into a bit more detail about the research I've been doing around the Body Project and yeah, and what that looks like and ways to get involved and such. So to start off, what is body image and why should you care? Well, what I quite like about body image these days is I remember, say, when I first started working in the field of mental health, the discourse kind of changed in that we started talking about mental health like it existed on a spectrum, like we all have health, therefore we all have mental health that can be positive or it can be negative or it can be neutral. You might have heard that saying, you know, there's no health without mental health. I guess I'd argue that there's no mental health without body image because we all have a body, we all have a way of thinking and feeling about that body. It might be that it's negative, it might be that it's positive, it might be that it's somewhere in the middle, that neutral. And I think that's important to remember when we're talking about body image. It's not just something that affects a subgroup of our population. I guess something we're really kind of trying to overcome in the field of body image and eating disorders is that these things are just something that affect like affluent, middle class, white, adolescent girls. The reality is it affects everyone. So I'd really like encourage you to have that mindset as we're going through this talk. But if I was to refer to the research, the body image is defined as this multidimensional set of thoughts and feelings related to the physical experience, the appraisal of, and satisfaction with one's body. And these multidimensional constructs are separated into four. We say we have perceptual body image, and that's how you see yourself, how you perceive yourself. We've got cognitive body image, so the way we think about our body. We've got affective body image, the way we feel about it. And I guess as a result, we've got our behavioral body image, so the things we do as a result of these things. And yeah, you might be somebody who likes how you perceive yourself, therefore you have positive thoughts about your body and feelings about your body, which are positive, and as a result, your behaviours are aligned with that. You might be someone who's quite indifferent. Maybe you're somewhere in the middle, like neutral about your body image, maybe how you see yourself. You don't really think about it all that much. It doesn't consume your thoughts. You might think, yeah, it's all right, doesn't really take up much of my life. And therefore your behaviors will align with that. You'll do what you want, you'll get on with your day, and thinking about your body image isn't something that occupies your brain. However, on the other end of the spectrum, it might be that you're someone who perceives yourself in quite a negative way. Therefore, you have these negative thoughts and negative feelings about yourself, and your behaviours will align with that. And yeah, that's what we would describe as, say, body dissatisfaction or negative body image. I would describe negative body image as quite a profound public health concern. I will go on to talk about the specific mental illnesses that can develop because of negative body image. But before that, I'd just like to highlight that those aren't the only trajectories for somebody who is struggling with their body image. We have research that indicates that people with a negative body image are at an increased risk of self-injury, for example, and other risk-taking behaviours like alcohol and substance misuse, smoking to control the appetite, unprotected sex, and even we know that negative body image can have an economic impact, so it can prevent women and girls going for jobs or promotions in the workplace. But we know as well that it can affect education. We know that there's a lot of school absences that can be caused by body image, specifically body dysmorphic disorder. And we know that engagement in school can be affected by negative body image as well. That's up to college and university. So like I said, these severe mental illnesses, eating disorders and body dysmorphic disorder, or BDD for short, you might not be super familiar with them. I know there was somebody in the chat who said that they works in a specialist eating disorder service, so that's fab, but you might not have come into contact with them too much in your roles. So I'm just going to give a really brief overview of what these are that I'm talking about. So again, I find it really useful to conceptualize eating disorders on a bit of a spectrum. So this could be a spectrum of behaviours which are characterised by what we'd call maladaptive food-related and eating behaviours. So that could be that someone's engaging in restrictive eating behaviours, so really trying to limit their amount of intake, or binging, where they would have episodes of taking objectively large amounts of food, or purging, where they would try and get rid of that food by various means. And I think what's quite interesting with eating disorder research is we don't actually have really good prevalence statistics at all. But what we do have, like our best guess, is that we have around 1.25 million people in the UK experiencing an eating disorder. But that statistic in itself was calculated 8 years ago and using various different sources. So it's not an exact science, but it's the best we've got, like I said. I think what's interesting as well is when we break that down and see the proportion of people experiencing these different types of eating disorders. Like I said, eating disorders exist on a spectrum, and you might recognise some of these terms. So I imagine most of you, if not all of you, have heard of anorexia or anorexia nervosa. And that is probably the most widely known eating disorder. But interestingly, that only makes up for about 8% of people experiencing an eating disorder. Even less than that is eating disorder called avoidant and restrictive food intake disorder, and that tends to be more aligned with autistic young people's experiences and sensory difficulties rather than having that core motivation of body dissatisfaction. So the types of eating disorders that actually make up the majority of people who have an eating disorder are, so we have binge eating disorder, that's around 22%, we have bulimia at 19%, but this group of people who don't fit in any of those types of diagnostic categories, there's nearly half of people with an eating disorder who fall in that bracket, which is quite interesting. I think if you compare it to like other mental illnesses and other mental disorders in the DSM, usually if you have that bracket of otherwise specified or doesn't quite fit in the other categories, that makes up sometimes like 5-10%. But for half of our people, like half of our people in the UK with an eating disorder to be experiencing that, I just think that tells us something about maybe how our diagnostic labeling isn't the best and most efficient. I mean, it's not, because we know that all of these diagnostic labels, for example, were built upon the eating disorder stereotype that I mentioned before, that idea that the only people who can experience these types of problems are your adolescent girls, mainly from an affluent background, who are white. Well, it's only actually recently that amenorrhea, so the loss of your period, was removed from the DSM because well, not me personally, but people wanted to make it more inclusive for different genders who were experiencing eating disorders. Because we know these days that statistics are showing us that up to a third of people with an eating disorder could be male. And we know as well that for non-binary individuals, at least 1 in 4 will be experiencing an eating disorder as well. But gender isn't the only characteristic where there's been problems in sort of building constructs and understandings and treatments based on just one-dimensional identity. And I'll talk in the final section of today's talk, I'll talk a little bit more about ethnicity and the role of ethnicity in understanding eating disorders. But sorry to be all doom and gloom for a minute, but I guess I'm so used to when I'm doing these talks trying to convince people that body image and eating disorders are something that are important to address in school settings, that I do think it's important to include some of the prognosis here. It's not great. We know, you might have heard this, but eating disorders have the highest mortality rate of any other mental health disorder or illness. We know that at least 1 in 5 people with an eating disorder will die prematurely as a direct result of their eating disorder, mainly because of cardiac complications, suicide, or other complications related to their physical symptomology. This statistic is also quite harrowing. The mortality rate associated with anorexia specifically is 12 times higher than the death rate associated with all causes of death for females in that 15 to 24-year-old age bracket. And unfortunately, I think these statistics are underestimated because in the UK, deaths related to an eating disorder aren't always recorded that way. So somebody might have, heart failure or organ failure on their death certificate when actually the cause was because of an eating disorder. So yeah, I think it's just important to recognise that. I think what I'll say as well about eating disorders is there's so many different causes to them. It's really multifactorial, and we've really tried our best as researchers to understand these different biopsychosocial influences that all come together to create the perfect storm for someone to develop an eating disorder. And so you can see here in Roger's biopsychosocial model that she's really highlighted this mechanism of internalization and comparison and how that relates to body image concerns and the role of social cultural influences, as well as general sort of psychological traits like depression, self-esteem, low mood. And similarly, when trying to look at, okay, well, what is causing these things specifically, the Thompson tripartite model really indicates that there's 3 main influences on the mechanisms that cause body dissatisfaction, and that's media influence, parental influence, and peer influence. So those are the different things going on, which some researchers think are important to prioritise when we're developing interventions to address this. So just quite similarly, I wanted to talk about body dysmorphic disorder, because although it is categorised differently from eating disorders, it's categorised currently as an obsessive compulsive related disorder, an anxiety disorder, but it does have that shared component of body dissatisfaction. It's characterised by this severe preoccupation with what we call a perceived flaw that often goes beyond weight and shape and is focused on something like someone's skin or other body parts or other facial features. But that also leads to an engagement in quite repetitive, compulsive behaviours to try and remedy these obsessive thoughts and preoccupations. And again, sorry to be all doom and gloom, but it's it's not just girls being vain. It's got an equally poor prognosis to eating disorders. We've got a 45 times increase in suicidality risk in the general population. So, yeah, this is one that's specifically been highlighted as a cause for significant school avoidance. So hopefully at this point, I've convinced you that body image and eating disorders are worth addressing in a school context, and they're important and pressing public health concerns. So what I'm going to do next is just talk about what are some of these opportunities you might have when working in a school setting to intervene, and also how do these kind of align with what the policy landscape is saying. So I've just highlighted a few policy initiatives from over the last few years that have had some significant proposals in them. So I'll take you back to 2017, first of all, and I think those of you working in MHSTs will be quite familiar with the Green Paper. If you remember, the Green Paper was the policy initiative that really set out and established the new service model of mental health support teams. So for those of you who aren't aware, mental health support teams bridge that gap between educational settings and specialist child and adolescent mental health services. And it was suggested that part of their remit would be to deliver group-based interventions which engage participants in critiquing the thin ideal, which we know can be effective in reducing eating disorder risk factors and symptoms and body image concerns. So the intervention they're describing here is the body project that someone already mentioned. And that is a type of intervention called cognitive dissonance-based interventions. But I'll come on to that in a couple of slides' time. Additionally, a couple of years later, this was just after the pandemic started, actually, the Women and Equalities Committee conducted a national body image survey as part of their inquiry into body image. And they really highlighted that actually our young people are super keen to learn about positive body image at school, but less than a quarter of the young people who were surveyed said they had ever learned about that in a school setting. So a bit of a mismatch between demand and supply there. But I think really encouraging to know that it is something that is on young people's minds and something that is worth covering. And then a couple of years after that, we had the impact of body image on mental and physical health inquiry ran by the Health and Social Care Committee. I was doing my secondment there at the time, actually. And what I didn't influence it too much, but what came out of the evidence was that there was a real gap in the EMHP curriculum, so educational mental health practitioner curricula, people who make up the mental health support teams, right? And it'll be interested to hear if those of you from MHSTs who are here today agree with this conclusion from the inquiry, that there was a bit of a gap in learning about body image and learning about BDD, and that was something that was reflected in the Health Education England curriculum for improving what used to be called IAPT. The artist formerly known as IAPT, I think we call it talking therapies now. But yeah, back in the day, we said improving access to psychological therapies, didn't we? But yeah, there was a gap here that was recognised, and I think that was quite encouraging, really. And then finally, and most recently, we've got the most updated RSHE guidance, and we do get recognition of body image under the heading of online safety, funnily enough. So the emphasis here is in ensuring that young people are building social media literacy, and that is a protective factor for them developing body image concerns. So yeah, lots of really interesting work going on here, especially in the context of the online safety bill, and yeah, more devolved powers to our regulatory bodies. But that's a whole other talk that I could spend an hour just talking about that. Interestingly, when it comes to eating disorders in RSHE, the guidance really points to, it's not in the curriculum, but for secondary schools, they said that topics like eating disorders and self-harm can be taught about, but in a safe and sensitive way, because they're considered specialised areas. So schools should really rely on qualified support, advice, ensuring that they're using reliable, high quality, evidence-based material, and signposting to external support where appropriate. So I found it really interesting following the policy landscape and how it talks about body image and eating disorders over the years. But what I do feel about it is it's quite piecemeal, but by which I mean it's quite fragmented, and it doesn't, all these like ideas and proposals and suggestions, they don't always fit together nicely. So I tend to look at body image, if we're calling it a public health concern, well, a public health issue needs a public health lens, right? So I always find it really helpful. You might have seen the public health model before, but it just really illustrates that there's intervention needed on various different levels. So if we start at the bottom here and think about what, universal intervention could look like, well, this is interventions for everyone, right? This is at a population level. So thinking about your whole school approaches, your assemblies and your classroom-based interventions, what can you do for everybody to promote a positive body image? And if we're thinking about prevention, trying to prevent the onset of eating disorders or BDD. When you're looking at this sort of middle chunk, we're talking about more selective and more targeted interventions. So interventions for, say, high-risk groups or groups who are already developing some risk factors for those types of disorders I described, but aren't quite at that clinical threshold. But even for that small number of people who will reach that clinical threshold and who will develop, the clinical levels of an eating disorder or BDD, there should still be specialist interventions and considerations for that group as well. So I'll just go through each of these now and share, I guess, some evidence-based tools and strategies that I've come across over my years working in this field that it might be helpful for you to go back to your settings and do a bit of research on and see. You might already be working with some of these organisations or tools, or there might be one that you've not heard of before. But yeah, I very much invite you to explore what would work well in your settings. And of course, we can talk about this later. But if we start at that bottom level, so that universal level, so thinking about your whole school approaches, thinking about your classroom or assembly-based interventions, there's a few things out there that could really help. So I don't know if anyone's heard of the Body Happy Schools program. So they work they work under the whole school approach framework. So ensuring that, there's policies and that there's just lots of different things working together at different levels to ensure that everybody has access to body happy, what we call body happy literacy, resilience, kindness, and advocacy. So that now has a really robust emerging evidence base, and I'd implore you to go and have a look at it. There's also a really good resource from STEM4 around developing a school-wide eating disorder policy, and I'd really recommend you take a look at that. Again, that's an intervention that affects everybody. And then we've got some more specific interventions. So I don't know if you've heard of the Dove Self-Esteem Project before, but they've been collaborating with colleagues over at the Centre for Appearance Research in Bristol for many years now, over 20 years actually. And they've been developing and researching, evaluating these school-based interventions, which are either single or multi-session. And there's things on offer for a whole a whole wide age range. So you've got Loving Me for 4 to 6 year olds. That was where I worked with colleagues to develop a micro intervention, where I don't know if anyone has kids and works with Blip or works with kids and you know of Blippy. I refer to him as like the American Mr. Tumble, but he's like a YouTube star, and we created I say we, like the team created a music video that encouraged body functionality and body appreciation, and it's really cool. So definitely have a look. They did amazing work on that. And then we've got some resources for 8 to 10 year olds as well as 11 to 14 year olds. So going up to like mid secondary school. And if you wanted to use something different, we've got the PSHE Association guidance. So if you did want to sort of stray from the Dove Self-Esteem project and there was another resource that you came across, another toolkit, I'd still really encourage you to have a look at the PSHE guidance on the key standards in teaching about body image. And the DHSC even has a lesson plan now for body image in a digital world. So yeah, there's plenty out there, and there's probably more if you look for it. But these are just the ones that I know have an evidence base behind it, so I'd be more confident recommending. All right, just moving on to that sort of middle section now of the public health model, so more targeted interventions. So like I said, this is when we're working with a smaller group, maybe a group that are already displaying signs of emerging body dissatisfaction or low self-esteem, perfectionism, for example, but aren't yet at that clinical level of an eating disorder. And it might be that there's some mental health support team offerings which deliver small group or individual work on these risk factors like self-esteem, confidence and perfectionism. But I'm quite interested in how we get that proposal from back in 2017, rolling out the body projects, how we get that disseminated as widely as possible. So for those of you who haven't come across the body project before, it's really quite strange as a researcher to see one intervention really dominate a whole field, but that's what it does. It's one of the most widely evaluated interventions, and it's the results from, say, longitudinal studies and RCTs have been replicated in different global teams across the world. What we have here in the UK is like a centralised training body run by Professor Philippa Dietrich, who has collaborated with the creators of the Body Project from over in the States and sort of brought their train the trainer model here in the UK. So I imagine if some of you have had that training, it's probably through Everybody Consulting. And what's really cool is they've also, as part of their offer, deliver booster training. So the adaptations of this intervention for men and boys and for LGBTQI plus youth. Again, I don't want to give you too many spoilers around the Body Project because that is the sort of like next 10 minutes. I'll talk about that. But just finally on this section, I wanted to highlight again that smaller group of young people who might already be reaching that threshold of a clinical eating disorder. I think there's still opportunities for intervention there. So I think what's important to consider for this group is, are you sort of trained to spot the signs? Would you know what an eating disorder might, I say, look like? We know that eating disorders don't have a single look, and that eating disorder behaviours can be exhibited really differently. But do you know that range, and would you be able to spot the signs in someone? Would you be confident spotting the signs for someone who might be experiencing binge eating disorder or bulimia as much as you would be with anorexia or ARFID? And I think that's something that I always want to remind people when we're talking about eating disorders, like it's not just anorexia, there are other eating disorders as well. I think importantly for this group, we need to make sure that we're aware of our local children and young people's community eating disorder services. So this was an NHS England and nationwide programme to get a more specialist eating disorder treatment for young people. So it'd be good to know wherever you are, do you know where your service is? Do you know your school liaison? Have you had training from them on how to write an efficient referral? Do you know how you might accommodate reasonable adjustments for people who are in treatment there? Do you know what might be needed for students to be able to maintain their recovery and make sure the school and the CYP KED service are aligned on what they're doing? I think as well, if you're not, fine, but there is a really good resource from the School Nurse Association here around how to support someone with an eating disorder in an educational setting. And there's loads of good ideas there for things like reasonable adjustments and things to consider for someone who is actively trying to recover from their eating disorder. So finally, I wanted to, like I said, go into a bit more detail about that middle level of intervention, talk about the Body Project and what I've been doing over the last, I guess, 7-ish years with my PhD and postdoc. So sort of told you this already, Body Project is most widely used intervention and most widely evaluated intervention. It's based on a theoretical model where body dissatisfaction is quite central. It's positioned as the most modifiable risk factor. And I think that's just really important to flag because, you know, as I said before, how we've got all these different potential causes of an eating disorder spanning from, say, genetics to physiological risk factors, psychological risk factors, social risk factors, all social determinants. But this evidence base is built upon body dissatisfaction being the most modifiable. And I guess what's meant by that is when you look at the resources of a school setting and a classroom setting, the Body Project is just everyone sat in a circle talking, essentially. Like, it's not super high tech. It's none of this like fancy VR stuff. It's just people sat there really challenging the appearance ideal and engaging in various verbal, behavioural and attitudinal challenges to ensure that their behaviours will align with these new attitudes that they're developing around the appearance ideal. And that's called cognitive dissonance, if anyone's interested. Now, what I really like about the evidence base for the Body Project is that it's kind of addressed that issue that I've mentioned earlier about all of our research being quite rooted in the disorder stereotype. Well, the Body Project's acknowledged that, and you know, it has received criticism for being rooted in westernized or Eurocentric beauty standards and ideals. And as a response, various teams have developed adaptations either for men and boys, where they've called it more than muscles, and they focus more on the muscle dysmorphia aspects of body dissatisfaction. There's been one called the Pride Body Project for gay men. There's been some RCTs for randomized control trials, sorry, for different ethnicities and different cultural groups. And what I've been really interested in is when people have made cultural adaptations with different communities. And there's been one example in North America looking at the Orthodox Jewish community and one over in Saudi Arabia as well. And that was the sort of methodology that I wanted to use for my PhD. Because I was really interested in, you know, all this amazing work going on, evaluating the Body Project, but then looking at what we've got here in the UK. And there is some really good stuff, mainly led by Philippa's team and some stuff going on in the Northeast as well in Durham. But there's not loads. And the quantitative studies have all really aligned with the evidence base. What really struck me though was the qualitative evaluations, and they were showing that the girls who were taking part in the Body Project thought there was too much of a focus on weight, so weight and shape was kind of over evaluated in this intervention. They were wanting more diverse appearance concerns to be addressed, and they wanted to talk about different body parts, hair colour, skin colour. And not only does this sort of align with a more transdiagnostic approach, by which I mean, you know, it could prevent BDD rather than eating disorders, like I mentioned before, but when we're saying things about a more diverse appearance ideal, we must be thinking about, you know, the different groups of people who experience body image differently. And this, plus the context of the pandemic, where we saw a disproportionate increase in hospital admissions for South Asian adolescent girls for eating disorders made me have the idea for my PhD, where I wanted to look at implementation of the body project in this UK context and start by exploring what body dissatisfaction in our largest ethnic minority group looks like. So I wanted to identify areas of the body project that would benefit from cultural adaptation, like those other studies did, but looking here with the British South Asian community. And this is essentially like the product of 5 years of my life. I think these slides will be shared, so you can have a proper look at this. But essentially, this highlighted some of the culturally specific risk factors for British South Asian girls. And I think the main thing to highlight here is there's many risks that interact with each other on different levels. So in the original version of the body project, you know, appearance ideals were based upon celebrities like Kate Moss or Elle Macpherson. Well, that's not really going to cut it with this group, where their body image concerns are stemming from, say, racism and colorism and skin tone discrimination. Or, you know, a big influence on their body image is the historic targeted public health campaigns on older generations, where there's been an emphasis on different BMI thresholds and different levels of risks for things like type 2 diabetes, or, you know, the I guess conflicting role of Western appearance ideals versus, say, Bollywood appearance ideals and South Asian specific media. Plus different things going on at a community cultural level. So thinking about the role of religion and the emphasis on marriage from a young age, sometimes arranged, sometimes love marriages. And then there's different sort of individual factors as well. So with this group I've been working with, it's been coming out that there's some quite significant hormonal differences. So earlier onset of puberty, higher prevalence of polycystic ovary syndrome, which all have an impact on appearance and therefore appearance concerns. But yeah, the paper is coming out hopefully in the next couple of weeks. So do have a look, or I can circulate it if you like. Essentially, what we did with that model we created is we mapped that onto the body project and highlighted some of those, I guess, mismatches where the cultural specific risk factor wasn't really being met by the content of the body project. And that from that we developed some recommendations as well as some overarching recommendations in order to adapt the body project. Just conscious of time, I'll just quickly tell you about the postdoc plan and then stop for some questions. But yeah, like I said, really lucky to just be able to keep building on this work for the next couple of years. I'm currently in the co-production phase where we're actually co-producing like the new adaptation, which is super exciting, and getting ready for the pilot phase where we're getting schools on board and working closely with mental health support teams to be able to train them to co-deliver the adapted intervention with us in schools. When I say the adapted intervention, essentially what we're doing is going through the intervention script and adapting it to ensure there's culturally appropriate language, prompts and examples, there's an appropriate facilitator guide, a young person resource, as well as a parent and carer resource, which explains the intervention in a really culturally appropriate manner. And yeah, like I said, really, really hopeful to collaborate with mental health support teams on this project, who will be really quite integral in supporting the logistics and, you know, getting us into schools and getting us, yeah, face to face with young people who hopefully will benefit from this adaptation of the intervention. Right, so that's me done. I'm really looking forward to some discussion or some questions if you've got any. I guess if you've literally been snoozing for the last 40 minutes and you've just woken up and you want to know in a nutshell what we've been talking about, I'd say that body image, please remember this is a public health issue which affects everybody, regardless of gender, regardless of ethnicity, culture, age, socioeconomic status. It's important we consider body image in schools because it can lead to those serious mental health conditions that I described, eating disorders and body dysmorphia. Schools are well placed to protect from the development of body dissatisfaction and other risk factors. and there's opportunities to intervene at multiple stages and levels. And if you want to get involved in my research or you're keen to learn more, please do reach out. I'm more than happy to have an email or a chat with anybody. And yeah, thank you so much for listening. If you did want to input directly into the call for evidence as part of my postdoc, that would be amazing. Again, these slides are getting circulated, so you can just follow that link there. But otherwise, yeah, thank you so much, and happy to answer any questions.